Welcome to Monetizing Innovation. I'm John Holcomb. Innovation isn't just the big idea on the whiteboard, it's the hard decisions, the missed signals, and the leaders who keep moving forward anyway. This show dives into real stories behind breakthroughs in life sciences, healthcare, and tech, how ideas become results, how teams align under pressure, and how strategy turns into execution. If you're building something bold or looking for clarity to lead with confidence, you're in the right place. Press play and let's turn innovation into impact. And thank you. Today we have a very special guest, Mary O'Connor, and she is a nationally recognized orthopedic surgeon, digital health leader, and patient centered care innovator. Dr. O'Connor is the founder and CEO of Vori Health, a value-based musculoskeletal care platform transforming how patients experience orthopedic care. Formerly the chief medical officer at Yale New Haven Health, she brings a rare blend of clinical excellence, executive leadership, and innovation expertise. Join us as we discuss the future of musculoskeletal care. Say that three times fast, right? And value based healthcare models and what it takes to lead meaningful transformation in medicine. And thank you so much today, Mary, for being here. We're honored to have you on the show and really excited about, especially your background in medicine, innovation, and business.
John, you're very kind. I am the Chief Medical Officer and founder at Fori Health. My role at Yale and Yale New Haven was the director of the Center for Musculoskeletal Care. So, just a couple little nuances there, but I'm delighted to be with you and your audience today.
Thank you so much. I think if it's really rare to have that blend, right, of the clinical background along with the business background and, to some degree, the extensive background in healthcare. When you look at Vori Health and how it's reimagining musculoskeletal care, what are some of the systemic problems in traditional orthopedic care not urgently or most need
Oh,
urgently need to change?
John, we could take just 2 hours on that because that is a fundamental problem. I'll give you the kind of the big highlights. So, patients, I'm a surgeon, and I'm going to preface this by saying the patients that need surgery that are clinically appropriate for surgery can be life altering, right? Surgery is a wonderful treatment for the right patient. Unfortunately, we know that there are a lot of patients who are receiving surgical care that basically could have gotten better without surgery, or they're not appropriate candidates for surgery. So the system, unfortunately, is kind of structured to not catch these patients and not divert them to better, more effective non surgical care. And why is that? Because patients will go from their primary care doctor, who traditionally is not well trained in orthopedics and spine. And I say that gently because like the primary care doctor has to manage all of these medical conditions for a patient. So you cannot be master of everything. So the primary care doctor refers the patient to the orthopedic surgeon or the spine surgeon, or the patient self refers. And surgeons, because we're surgeons, have a surgical treatment bias, right? So there's a natural inclination to offer the patient an operation and not to try good non-surgical care first. And surgeons now are not even well trained in non-surgical care. So fundamentally, the way the whole system works, we're missing the opportunity to help patients get better without an operation. Secondly, the system is financially geared towards surgical volumes, advanced imaging, and procedures. And why is that? Because all healthcare systems, their financial margin is dependent, I mean, John, dependent on the volume of surgical cases, advanced imaging, and procedures. Why? Because these are service lines that are profitable for them, and they need the profitable service lines, orthopedics, spine, advanced imaging, right? To offset the losses on the service lines that are never going to be profitable. Pediatrics, OB. So if you're running a healthcare system, you have to have pediatrics, OB, infectious diseases, endocrinology, these other areas in order to provide medical care, right? but they won't even break even. So it's the kind of cost shifting to generate the margin to keep the overall system afloat, supports overutilization, because there is no surgical health system administrator that says, yeah, I want to lower my number of surgeries done in my health system next year. There's no one that does that. And so, however, right, we have to recognize that there are inappropriate surgeries that are happening. And if you look in the literature, it can be 40, 45, even 50% for some low back surgeries. Knee replacements, there's a study that it's 34%. I mean, these are not insignificant numbers, not just in terms of the cost today and now,
Mhm.
but risk to the patient for postoperative complications, the cost of managing those postoperative complications. So we need a new way in musculoskeletal care, and that's why we created Vori Health.
No, that's fantastic because I do think you point out so many of the challenges, right? And it's not for malintent. It's just that's the way the system is structured. And when you look at that, how do you think that has challenged in terms of Bori Health to step up and address some of these challenges?
Well, it's really the opportunity for us and a differentiator for us, because we are the only company
Mm.
that does what we do, that is structured as we are as a medical practice. So there are some other companies in the call it the telemedicine MSK space. They are focused on virtual home exercise programs, some providing some physical therapy, others really focused on the home exercise program, but not actual physical therapy. But they are not medical practices. So that's what's different about us. So we have doctors, nurse practitioners, physical therapists, physical therapy assistants, exercise physiologists, health coaches, registered dietitians. So our model is really to surround that patient with the care team of appropriate clinicians to optimize the opportunity for them to improve without surgical care. For example, if we took patients with low back pain, and like most adults in the US, I mean, people have low back pain. Like it's so incredibly common, right? But for people that have consistent low back pain, if we did nothing but improve the quality of their sleep, we improve their back pain. Who focuses on sleep quality in the traditional healthcare system, which is actually a sick care system, right? I, as an orthopedic surgeon, I'm not trained on how to really promote health and wellness. I am trained on how to address illness and disease. So, like, if I really wanted to go
Right.
high level with you, I'm like, we need to move wellness and health into communities, and we need to make the healthcare system focused on taking care of sick care, right? So, our model is a biopsychosocial model where we are paying attention to these other factors that are going to influence the health of that individual, and not just their health, but their ability to improve their musculoskeletal condition, right? If you're overweight and you have knee pain, if you lose 10 pounds, that is a reduction of 30 to 60 pounds of pressure on your knee joints. Duh. Okay. But how do we help that individual lose weight? Right? How do we help them with an exercise program? How do we help them with an anti-inflammatory diet? Not everyone needs a GLP-1, although that has dramatically, obviously changed the treatment of obesity. As you probably know, for the first time in forever, right? The percentage of adults in the US with obesity has declined. And I personally think that's all related to the advent of the GLP-1s. But we also know with GLP-1s, there's a risk of sarcopenia. They lose muscle mass. So, like, we were looking at patients as the whole individuals that they are and supporting them with health coaching, which is the primary tool for cognitive behavioral change. I'm going to help you improve your sleep. We're going to set SMART goals, which are specific and measurable and actionable, to help you change your behaviors, because it is still our individual behaviors that contribute most to our health outcomes. It's not actually access to medical care. It's not actually socioeconomic, demographic factors. Those social determinants of health
Mhm.
are important. They matter, but it's our individual behaviors that people underappreciate how critical they are. And so in our model, we strive to help recognize those and help individuals address them. I tell folks we're not anti surgery, we're just anti inappropriate surgery. And we refer patients to surgeons because sometimes surgery is the right treatment. But, let's support them with good non surgical care through the convenience of telemedicine. It is so much easier, to get on a video call with your doctor or your physical therapist. And, once patients
Uh,
start with us, even, patients that our physical therapists have said, hey, I think that maybe a couple in-person visits with a physical therapist, and we have contracts, we have partnerships with thousands of PT clinics across the country. Let's send you for a couple in-person PT visits. They're like, why can't I? But but I don't want to take the time. I gotta drive there. I gotta check in. I have to wait. I see the therapist. I gotta drive back home. People are busy.
no, that's very true, and I think to your point, having that approach and recognizing some of those challenges, because even patient compliance is a huge thing, right? What, like you said, even the behavioral aspect of just having a health and wellness plan, it does come back to that. Yeah,
You
I
know,
love. Go ahead.
One
I'm
other
sorry.
no, just one other comment. We built the company for value-based payment models. So we don't live in the fee-for-service world, and that's what allows us to utilize this more biopsychosocial model where we can bring in health coaches and registered dietitians because like in traditional insurance and Medicare, you need to be diabetic and have like stage 3 chronic kidney disease before you're going to get approved to see a registered dietitian, which is just craziness, right? So, a part of what we focus on when we're negotiating with a payer with this contract is we do not want any out of pocket costs for the patients. Because once you do that, patients will automatically stop and stop doing what we want them to do because they have to pay an out of pocket. And that can add up to a lot of money for a lot of patients, right? I mean, $40 a PT visit, that adds up really quickly.
Yeah, absolutely. And, especially if you're going twice a week or anything like that, it can become cost prohibitive.
Right.
Well, and I love how you bring that approach too. And you've touched on this already, though, is that value based healthcare and practice. And so when you look at, you know, the healthcare system and some of the problems that you've pointed out, it's clearly a challenge, right? In terms of it sounds easy on paper, but you're living through those challenges through your practice. What are some of the lessons that you've learned, especially about making those value-based models actually work for the patients, the providers, and the payers?
The further upstream that our clinical team can get in terms of the journey of the patient, the more effective we are at driving appropriate utilization, which will translate into savings for the payer. Like, we're not like our goal, we don't say, like, oh, I don't say to my clinicians, go save money for this payer. I say to them, go deliver great care for this patient. Utilize evidence based criteria for whether the patient needs an MRI ordered or not. Okay. So, our utilization rate for things like imaging and, in particular, advanced imaging is much lower than what you would see in that kind of normal practice. And that kind of intersection point, John, is so important
Mhm.
because it's typically the advanced imaging scan that will lead the patient down the surgical pathway, whether that's the right pathway for them or not. And part of that is because like MRI is such amazing technology.
Mhm.
Like when I grew up in medicine was first developed. In fact, we used to call it nuclear magnetic resonance
Mhm.
imaging, right? And then people didn't thought the nuclear part would be scary to patients, so changed to magnetic. So the ability of these scans to show us tissues and changes is so powerful. But it shows us so much that oftentimes what it's showing us is actually not the cause of the patient's pain. And this has been well studied and documented in the medical
Mhm.
literature, particularly for spine. So if I imaged your spine or my spine right now, right? There's going to be lots of changes because like we're not 20 years old anymore. And that doesn't mean that some disc bulge on my MRI is actually what's causing my pain, but it becomes the surgical target. And it's an easy thing for the patient to focus on to say, but this disc is bulging. And my doctor, my primary care doctor said, maybe that's putting pressure. It's putting pressure on my nerves. And that's the reason why I have my pain. So then it becomes this surgeon fix me, right? And there is no surgery that makes you as good as you were. That's the bottom line. And people, it's important for patients to try and, you know, truly understand that, which is hard when you're the patient because you just want to be fixed, right? You just want to be better.
Absolutely. And if you actually are given the hope that this might be the cure, right, then of course you want to go down that path.
I know, but they don't. I've done lots of joint replacements in my surgical career, and I would always tell patients this isn't like the joint that you had when you were 20. Like you have to understand knee replacement and hip replacement. Like if you're at the end of the road with arthritis, that is the only
Mm,
treatment that's going to make a difference for you. But it's not as good as the knee God gave you when you were a young person. Like don't have this expectation in your head because we will not need it.
absolutely. And I think that's such great perspective, right? Because it is easy to get lost in the noise, right, of everything that is going on in that environment.
Yeah.
So, one thing, and we've touched upon it briefly, but I would be really fascinated to learn about your transition going from, surgeon, clinician to the CEO. I'm sorry, my apologies. um, what are some of those things that really reshape your leadership style and decision making along the way?
Well, John, I've been on this kind of journey to transform the delivery of MSK care for a long time since I was chair of orthopedics at Mayo Clinic, Florida.
Mm,
And I incorporated some non-surgeon physicians into our all surgeon department. It was a thing of beauty. I was able to get the surgeons into the OR one more day every other week. I
mm,
mean, I could increase our surgeon capacity without hiring more surgeons, drove our contribution margin up by 19% from my department to Mayo Clinic, Florida.
mm,
I retired from Mayo in 2015 when I went to Yale to build this integrated
mm.
musculoskeletal center, right? And what I've learned in this journey is that these kinds of fundamental changes are incredibly difficult. No, I'll say impossible to implement in our current traditional system. And the reason for that goes back to the way the payment structure is and how a healthcare system simply cannot lower rates of surgery. If they do, they're closing it's not financially viable for them. So it's this, you know, um, innovator's dilemma, right? The classic Clay Christensen innovator's
Mhm.
dilemma. They want to innovate, but there's something major that prohibits them, which is financial margin, right?
Right.
So I realized that if I really wanted this to be my professional legacy, that I needed to leave the comfort and
Mm.
security of academia where I'd been my whole professional life and venture out into the entrepreneurial world. And like, why not? Why not? I mean, I've accomplished a, a lot in my professional academic career. There really wasn't much more that I would put on the box of, things I wanted to do. So I went for it.
No, I think that's fantastic, and I do think it's some of that courage and vision, right, to be able to how do we make that change, and how do we help also build the team around it to support that similar vision? When you look at that, what have been some of the, I'd say, the bigger challenges, maybe from a a team and leadership perspective of helping get folks on
Yeah.
board?
So that's a great question. And they're not big challenges, but there's little challenges that I deal with having our clinical team move from a fee for service mindset to value-based payment mindset. Like, we're not billing like fee for service. So, I mean, there's a lot of stuff that is part of kind of the culture that comes from the traditional system and is carried over because that's the system that they came from and that's where they trained and that's where they all lived, right?
Mhm.
Before Vori Health. It's incorporating, how do we incorporate new models of care delivery, new clinician types for when maybe that wasn't the norm before, right? We now have some exercise physiologists, and they're amazing. They're not replacements for our physical therapists, our physical therapy assistants, but yet they bring a different level of experience and a different focus. And so, okay, who are the right patients for our exercise physiologists to engage, right? How do we create the model where their expertise is really going to be of great benefit to the patient? And, like traditionally, not all clinicians are used to working with all the other kinds of clinicians, and they really don't necessarily understand exactly what they do and how they work. Why? Because traditional medicine is extremely siloed. I mean, I am telling you, it's beyond like I say siloed and people think, oh no, like the doctor and the surgeon and the physical therapist, they talk to each other. No, they don't. I don't know what planet you're on, but they don't. So, we have gone through different iterations of our care delivery model and our current version, which I remain very excited about. We've been doing it now for about a year, is
Mm.
our integrated visit for more complex patients is a 30-minute visit with the physician and the physical therapist together with the patient in the video visit. Like, whoa. Okay. Like no one does that. That allows the patient to tell one story that both clinicians hear. It's one virtual physical exam that both the clinicians can ask the patient to do different things. The physician renders the medical diagnosis, the physical therapist, the functional diagnosis. Everybody's on board. There's instant alignment of I'm the doctor, here's my diagnosis, here's the physical therapist, here's my functional diagnosis and what we need to do. The patient's right there. It is beautiful. It's beautiful.
That's wonderful because that's the true power of collaboration, right? And
Right.
really changing the paradigm.
But set up the system, right? Set up the structure to facilitate the outcome that you want. If you want collaboration, make it easy, embed it, make it inherent in the process.
And I love that example, right? Because I think what you've identified is such a common problem throughout all industries, right? As we develop these silos. And if we're not setting and defining that business outcome, there's not the opportunity, right, to really change from the inside. And it creates the ongoing friction. So it takes folks like yourself, the thought leaders, right, that are actually challenging the paradigm.
And it takes leaders on the other end too. Like one of our clients who's a self-insured employer, I've really, really enjoyed working with them. We are driving significant savings for them in the MSK space. And we have worked and evolved the model so that if one of their members, one of their workers, right, is told that they need an MRI by the local doc, that patient comes and sees us first, and our doc will review. And sometimes, yeah, it's appropriate for them to get the MRI. Sometimes not. Sometimes it's let's get you started on some non surgical care first. And you know what? If you're not improving, then we're going to order the MRI. And it's having partners, and by that I mean this self-insured employer, and
Mhm.
we're doing this with others too now
Uh,
because it's proven so successful, right? Like help us get upstream. Help us get upstream because the more upstream we are, the better able we're going to be to influence the direction of the care of that patient. And that's so helpful to us.
Yeah, I couldn't agree more because right, that really is about driving the appropriate collaboration where it matters. When you look at that too, because I can only imagine just, the difficulty, right, of creating that change. How do you see now when we start looking at things like digital health and the potential introduction of AI? Do you see those as potential tools that can also help facilitate the change that you're trying to drive?
Absolutely. So, we have to be careful with AI, and I don't think that patients ultimately want an AI doctor. What they want is they want their doctor to be empowered and supported by AI,
Absolutely.
right? And that's how I view it. But AI has, and I'm not going to talk about like AI with the mundane things like, well, let's use AI for scheduling or let's use it for, kind of these very administratively heavy processes,
Mhm.
right? But where I see a lot of potential power with AI, and we're working on incorporating this into our model, is to support that individual with some of the behavior change that they need, right? So where's the gentle nudge? Like for example, and it's like a little example, but it really highlighted to me how powerful this is. So there is a company that we were looking at, and they are a health coaching company, and it's basically all AI driven, right? So I'm trialing the product and I put in there, what do I want to work on? Better sleep. I don't sleep enough. I could improve, me personally, I can
Right.
improve the quality of my sleep. Okay. So the little behavior change thing was to read before bed, right? Even if that's 3 pages. And this was a long time. I mean, this was probably a year ago now that this, right? And I get these little nudges, and not every night, but a lot of nights now I have a couple books next to my bed, and I will open that book. And even if it's just a couple pages, it helps my mind just shift gears from all of the work of the day or the other project that I haven't finished or the email that I didn't get to. The stuff that I say at the end of the day, this has to wait for tomorrow, but it's still kind of there in your head, right? And,
Absolutely.
and like, so these little nudges, right, are what help us with behavior change. Now, if I had a program that was even more AI driven, where I have an agentic agent that is now asking me, "Hey, Mary, how did you sleep last night?" And I can just go right into my phone. Great, or what I mean, like the more you can personalize it, the better. And of course, that won't appeal to everybody, and that's okay. But I think that people will find it can be quite helpful. Anyway, we're very excited about incorporating that, which will be next year, which is already like, last next year is and to get feedback from our patients about what they think. Because at the end of the day, it's not about AI, it's about the patient. And did they find this a helpful tool to help them on their journey towards better health? That's the measure. It's not a measure of AI.
I couldn't agree with you more. I think that's the biggest challenge, right? When people try to put AI first, and then AI is just merely a tool. We still need the excellent doctors, right? We still need to be focused on what the patient's needs are. And if we get that out of order, right, everything falls apart.
Yep. That's exactly right, John.
No, I really love the work that you guys are doing because I do think that holistic approach is just so critical. And when you think about, and you've touched upon it a little bit already, but as you look at some of the future healthcare innovators, what advice or guidance would you offer to folks, especially as they want to innovate within the healthcare system without losing sight of those patient outcomes, like you just mentioned?
All right, so I'll share something that you'll probably find not very sexy, but I think it's really important. One of the reasons why I was able to pivot was because my husband and I were not in debt, and like this is not like a high level topic, but I think it's really important because, I went from being a surgeon, director of a musculoskeletal center, well compensated, to I'm gonna make a startup compass, right? I am not gonna make nearly as much money.
Mm.
No, I'm not like, you know, we can pay the bills. I'm not complaining. I'm just saying this is like a fact. This is a reality. But part of the reason why I could do that is we didn't have a mountain of debt. So I advise young physicians and particularly young surgeons, like if you're thinking that you want to embrace at some point in your career medicine beyond direct patient care, then help yourself be in the position to make the pivot by having your personal finances in order so that you don't have to stay anchored to that surgeon salary. You can pivot and go and try something and innovate or be an entrepreneur and do something for which you're going to get paid a lot less. And you can only do that if your financial house is in order. Oh, you've got the college fund for the kids, the house is paid off. You don't have new car payments that you're making.
No, it's funny. Like you said, it's simple, but it's extrememe powerful. And it just even goes back to Maslow's hierarchy of needs, right? If you're worried about survival, it's tough to worry about others people's success, right? And I really think that that's a very wise observation because it allows you to be creative. You have that buffer that allows you to take some risk.
It gives you the freedom to take the risk. Exactly. Like I wouldn't have been able to do this earlier in my career from a financial standpoint, right? But my husband, we were pretty disciplined, and because we did that, I could do it. Like financially, I could do it, and so that's just it's just advice that I give younger physicians and surgeons because they don't always think about.
And absolutely, and especially too, with the cost of some of the education nowadays for doctors, surgeons, physicians, it's so easy to build up a mountain of debt, right? That has to be paid off if you're not smart about it. And I
Yeah, yeah, yeah.
and
I know. I mean, my first couple years of my real job, I was getting my HEAL loans paid off, and those were astronomical interest rate. I mean, you have to make it a priority and not kind of like we lived under our means to get out of debt.
absolutely.
And that's okay. I mean,
And
we don't need a
yeah, no, exactly, and I think it translates across industries too, right? Because it's that same basic principle is so true, and I really appreciate you sharing your perspectives today. This has been a wonderful conversation, and really excited too to continue collaborating, and hopefully, if we can continue to help each other, more than happy to continue to assist. Is there anything else you'd like to share with the audience before we sign
well,
off?
if people have an interest in learning more, reach out to me, particularly self-insured employers or people that are interested in lowering their their healthcare spend while knowing that they need a healthy workforce and they want to take good care of their people, right? And we work with a number of payers and insurers too because they recognize that they need to offer some innovative plans and innovative programs. So yeah, we're just having fun, working on making medicine better.
Absolutely. No, and I will make sure that your contact and detail information is in the write up for the podcast. And thank you for all the wonderful work and innovations that you have been driving in this space and really making a significant impact in patients' lives.
Thank you, John. It's really our honor to serve patients.
Excellent. Thank you so much, Mary.
Okay, have a great one.
You too.